So let's dive in and address the biggest objection. Digital can't handle complex work. You can't separate vergence from accommodation at home. You can't help the brain recognize miscalculation without in office precision. These are valid concerns because complex binocular dysfunction is not simple. So let's talk about what digital vision therapy is and what it isn't. Vergence adaptation is complex. Accommodation flexibility is complex. Ciliary body control is complex. EOM coordination is complex. Neurological recalibration is complex. Anyone who says otherwise doesn't understand the visual system. But here's the mistake we make. We assume complexity requires a fragile delivery model. It doesn't. Complexity requires structure, not necessarily proximity. When most doctors hear digital, they think exercise packets, YouTube videos, VR headsets, generic apps. That's not what I'm talking about. Throwing exercises at patients is not care. That won't outperform structured in office therapy. But delivering your full intellectual property, your sequencing, your reasoning, your progression logic, your troubleshooting framework in a structured, guided, supported way, that's different. Digital isn't about removing expertise, it's about extending it. We frame this as in office or digital. That's the wrong framework. The future isn't replacement, it's layered care. Complex cases may absolutely require in-office calibration, precision monitoring, skilled therapist oversight. But that doesn't mean every minute of therapy must be location-bound. Hybridization increases access. Access increases compliance. Compliance improves outcomes. Some doctors say, this is a PR problem. People just don't know what we do. And awareness matters. But let's be honest, if awareness doubled tomorrow, could your current structure absorb that demand? Or would waitlists grow, staffing strain increase, burnout accelerate? PR amplifies whatever structure you have. If your structure is fragile, PR accelerates collapse. That's why structure comes first. Digital, when done properly, solves geographic limitations, scheduling rigidity, transportation barriers, therapist dependency, waitlist bottlenecks. It doesn't eliminate complexity, it protects capacity. And when capacity expands, access expands. When access expands, leadership expands. The question isn't, can digital replace every in office nuance? The question is, can we afford to keep vision therapy locked inside our four walls? If our only model is one-to-one, in-office, self-pay, local only, access shrinks. And when access shrinks, influence shrinks. And when influence shrinks, leadership shifts. Digital is not about replacing vision therapy. It's about preserving it. It's about protecting the intellectual property we've built. It's about making sure complex binocular care remains in optometry because complexity doesn't die when delivery evolves. It dies when access disappears. If we want to remain the leaders in vision therapy, we must modernize how we deliver it. Not because it's trendy, because it's necessary.